Okay, let's get started. It's 12:30 on 24th July. And on behalf of the Sing Health Duke-NUS Global Health Institute, I'm delighted to welcome all of you to this webinar. It's really wonderful to have this our audience participating in this and kind of becoming part of the growing global health community which we have in Singapore and in the region. More than ever, we must come together to study, understand, and kind of learn from each other on important health issues that touch all of us. Today's presentation is part of our Global Health Seminar series, which we now present in this online format, considering that we can't do it face-to-face as we had done previously. These seminars are usually scheduled for the last Friday of every month at 2 p.m. This one was a little bit of a change because next Friday is a holiday, so we moved it to this Friday. We also moved the time because we had to accommodate our speakers' schedule, and I'm very grateful to all the audience to be able to accommodate that change, but do look out for our seminar series on the last Friday of every month at 2 p.m. I'd like to now introduce our speaker of today, which is Dr. Orlanda Goh, and Dr. Goh will talk about universal health coverage and its relevance for both Singapore and the region. She is a senior resident in advanced internal medicine at the Singapore General Hospital, and she has done a lot of work in the region as well as in Singapore. She's passionate about health services as well as looking at health financing interventions, particularly kind of focused on vulnerable populations in the region. Upon her completion of her Master's in Public Health from the Johns Hopkins School of Public Health, she was inducted into the prestigious Delta Omega Alpha chapter, reserved for alumni with outstanding academic record and contribution to the research and practice of public health. And I think that's for her is a key issue, is the practice of public health. And this was due to her work in Thailand with HIV-infected patients, commercial sex workers, and even undocumented migrants and refugees. She has working experience in health policy and evaluation divisions in the Ministries of Health in both Singapore and Thailand. And currently her research focus is on health services research in tertiary hospitals and interventions to reduce health disparities of migrant workers in Singapore. So we're really looking forward to kind of hearing her overview of universal health coverage and some of these specific issues. Before I hand over to her, a few housekeeping notes. As you might know, the webinar will be recorded. Please keep yourselves on mute, except Orlanda has kind of very graciously said she will be fielding questions at any time during the presentation. So that'll make it more interactive. Please, you can post it in the chat, or you can kind of raise your hand with that little kind of mechanical hand they have. And these will be addressed either during, if it's appropriate, or at the end of the presentation. So now, Orlanda, over to you.
Hi, good afternoon, everyone. Thank you, Amina, for that very kind introduction. So my name is Orlanda, and thank you for joining us in this Global Health webinar series today. I'm a senior resident with the Advanced Internal Medicine program, and I also lead a double life as a global health enthusiast, as I have been interested in health economics and global health since my days in medical school. So a few years ago, when the opportunity arose, I took time off work to live in Thailand, where I was explored the field and took out MPH. And it is personally unexpected, but also heartwarming to see the turnout today. So as I understand, we have colleagues joining us from a wide variety of fields with different levels of familiarity with some of the things we will discuss. So we don't have much time to discuss a very heavy topic, but we'll try our best. And the main objective today is to give everyone just a flavor of universal health coverage, or UHC for short, and how it's relevant to us today. And perhaps we'll have time to discuss more issues in depth during the Q&A. As some of you in the audience may be experts in the field, I welcome you to also participate verbally to offer your opinion in the Q&A session. And on that note, I believe that Dr. Rapipong Supanchamat, an expert in global health financing, might be among our audience today. So if he is, I would just like to acknowledge him in advance for some of the work that I will be quoting. I would also like to declare that this talk is not sponsored by any entity, and that the views expressed are of my own and do not represent that of any previous or current employer. Okay, so on that note, I will share screen and then we can start this presentation. Okay, so We will start off with an outline, and this is just to show you what we will be talking about later on. So we'll start off talking about UHC. What is it and what is the buzz all about? Then we will discuss some basics in health financing, including the concepts, definitions, the evolution and history, and challenges for both high income and low and middle income countries alike. Then we will also talk about some unique problems or challenges to the global community in this current state, and also talk about broad strokes in terms of some of the things we can do to kind of find solutions. We will also then talk about Singapore's health financing system, a little bit about Thailand's health financing system, and then talk about aspects of monitoring and evaluation that would be systems critically. So what is UHC? I think many people in the audience would have heard it mentioned quite a bit, both in the news and also in our career. And to start with, I think this little graphic here is a very useful graphic in terms of helping us conceptualize it. So we see an umbrella covering all sorts of things, different kinds of people and conditions. And essentially, universal health coverage is this aspiration that all people and communities can use the promotive, preventive, curative, and rehabilitative and palliative health services that they need and of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. So three key principles in the definition of UHC include people, quality, and the finances. And we will elaborate about on that in a bit. Just to give you a little bit of context, this idea came about after the WHO Declaration of Health as a Human Right in 1948. And as we all know, the UN and therefore the WHO was created by the international community post-World War, and that is how the concept of human rights actually started. And it is the concept of human right, and by extension health as a human right, only came about so that we could come together to set aside standards of living so that we say that everyone should be entitled to them, and it serves as a framework for the international community to collaborate in to protect people from the many ills of civilization today, so including but not limited to genocide, slavery, or even preventable disease. Subsequently, there was also this major milestone in public health where there was this Health for All Alma Mater Declaration in 1978, where again it was emphasized internationally that healthcare is an important kind of milestone in development that has to be reached. And in that declaration, there was a shift into the focus of public health, primary health care as one of the key core components to prevent disability and disease. And all this is in line with the SDGs, or the Sustainable Development Goals, that have always been emphasized by various development agencies over the years. And you see a graphic of that here. So in other words, UHC is also frequently referred to as the cube. So in this cube, it also helps us to conceptualize the three core components. So who is covered in terms of the population, and you see that reflected in the x-axis, which services are covered, and also by extension whether of course they are of sufficient quality. And in the y-axis you see the next question is how much of it is covered financially by the scheme that we are talking about. So different countries, all countries aspire to UHC, I would believe, but different countries differ in terms of the X, Y, and Z axis of the blue part of this cube here, which is essentially what they are currently covering in the UHC. And this is a helpful kind of framework that we can use to compare countries as well. This also just reminds us that this is really a topic of frequent campaigning. And again, this graphic is very useful to help emphasize that we want to cover people, and we do not limit the coverage to age, to disability. We do not limit by gender identity or gender preference, and we also try not to limit the kind of conditions. But of course, there's an aspiration, and it's something that's very difficult for many countries, and we'll talk about that in detail later. And the other thing I would like to emphasize with this graphic is just to say that it's just not enough to say if health services exist or not. And this umbrella is also a nice kind of icon to reflect that. So it's it's not enough to know you have umbrella. You need to know that umbrella actually works. And how we do that objectively is to really see if we have objective measures of monitoring and evaluation, and whether we can assess objectively the quality and affordability. So monitoring and evaluation is a key component of UHC and improving lives for other people, for people. So one core component that I will just discuss here, one of the three that I mentioned earlier, is the financial aspect of it. So what are we talking about in terms of saying this, talking about this idea to protect people from financial risk? So it is defined as a risk of not assessing or receiving care due to financial constraints. And we are also concerned about the risk of financial hardship due to catastrophic healthcare spending. So this is actually something that's more relevant for people in low-income countries or people who are of the lower income quartiles in society, because for the same kind of healthcare services, there's a higher risk that this may actually bankrupt the person or the household. And of course, there's a third risk, which is the risk of the loss of productivity from falling ill and not being able to earn money. In terms of the second core principle, which is of quality, you may ask, what does quality mean? Is there even a universal or a consensus, a universal definition or a consensus as to what it is? Yes, so we have an authority on it, which is the Agency for Healthcare Research and Quality in the US. And there are a few core components that we want to talk about in terms of quality. So medical care has to be safe in terms of the avoidance of harm to patients from care. And this is consistent with the Hippocratic oath to first do no harm. It has to be effective, meaning that the use is appropriate according to the latest guidelines and evidence. Care has to be patient-centered. It has to be timely, meaning that we do not want avoidable waits and harmful delays. It has to be efficient and equitable. And this is a key component of UHC as well, because we want to be mindful of the fact that we cannot ignore vulnerable groups which may be defined by their gender and ethnicity, their geographic location in large countries, or their socioeconomic status. So the third component then is equity. So before I go on, I would just like to invite everyone to just think about whether you think we automatically exclude some people or communities based on the structure of society today, or based on current regulations, healthcare policy, or the health services we provide. And I think many of you would perhaps think about the current affairs today. So this picture will remind us of the current problem of the Syrian refugees, and how as refugees, this is a big kind of challenge to universal healthcare, because there's currently no universal framework to ensure that healthcare refugees is appropriately financed. And closer to home, the other crisis, of course, regionally, is that of the Rohingya crisis. And this is an aerial view of Cox's Bazar in Bangladesh. And you can imagine, as a country that is still in its developing stages, it actually is really doing a lot for the humanitarian and health aspect of these refugees. But still, another question here is, how is this financed, and is it sustainable? And then closer to home, in recent months, we have been reminded of some gaps in the healthcare and the healthcare financing structure of the migrant workers in Singapore. And this photo of a dormitory will remind us of that. So the last component of UHC that's not part of the core principle, but something I want to bring up, is that the elephant in the room is that it is actually very much influenced by politics and policies, in the sense that it's just inextricably linked to the extent a country enjoys UHC. The simple fact of the matter is policies are influenced by a public discourse of the pros and cons, and also the political process. And in Singapore, in recent years, we've seen that as in terms of the timeline of events, we know that in 2011, there was a large change in the election results that we had in the country. And following that, there was also a change in the coverage that or level of UHC that Singaporeans enjoyed. And there's always this complicated interplay between the political process, policies, and to what extent a country enjoys UHC. So that is UHC in a nutshell. And if there are no questions at this point in time, I will just move on to health financing and the basics of that. Okay, so before I go on, I would just like to mention that, coming from the background of a doctor that was trained in medical school locally, I can see that, despite the lack of acknowledging it very head-on or frequently in training or in our daily ward work, the fact of the matter is money and medicine do always go together. And before we go on, I would like to take a pause and pose these questions to everyone out there, because your answers to these questions are very personal and perhaps shaped by the life experiences and personal values that you have. And there can be very varied and strong opinions on what health financing should be, but the truth is there's no one right answer. So now is a good time to make a mental note of what your answers to some of these questions, as it will frame your perspective of how good or bad a health financing system is. And we will talk about evaluation of what defines good or bad in a bit. But ultimately, our objective is for you to be better equipped to answer these questions. So how important do you think it is to know about health financing in your role at work? What are your values on health? So do you think it is a right, or do you think it's a privilege? Regardless, do you think health should be a personal or group responsibility? And if you think that it is a group responsibility, then should it be that of the government or civil society, or a mix of both? And who decides what weightage we place on either? And I guess more specific to the refugee crisis that we have internationally right now, do you think that this is the responsibility of the local government or international government? So now we'll move on to just talking about health financing and the technical concepts. So this is everything we need to know about health financing in one slide. When I first saw it, it was very intimidating, and I have to give credit to my professor at Hopkins who introduced it to me. But essentially, we can see that health financing systems are characterized by where money comes from, in terms of the donors giving international assistance, firms paying taxes and premiums, or persons or households paying taxes and premiums, and how they are pooled by different agencies such as the ministries of finance or health or manpower, depending on the country and the context, as well as depending on the insurance schemes that are in that country. And health financing is also influenced by the mechanisms of payment, or in other words, purchasing of health services. So this could mean global payments, or fee-for-service payments, or per capita or diagnosis-related group payments. And then health financing, the characteristic of health financing is also the kind of the nature of provision of health financing in that country, meaning what is the public and provider mix, and how are services organized. Then as we move on to people, or the true beneficiaries of health services, people or the households interface with health services through paying for healthcare either through taxes, premiums, or through a direct out-of-pocket payments. And as a result, they are covered for or access healthcare services depending on the insurance schemes and the healthcare structure that they have in that country. And of course, what differentiates countries would be their GDP, the disease burden, or the epidemiology of disease in that country, which also is in a way linked to the GDP and the stage of development, and also how the country's health policy is shaped such that healthcare services are purchased for and accessed or covered for in a particular way. So if you understand all of that, then you don't have to be in this talk. Okay, so then we move on to some of the definitions and concepts which are important, because these are terms that we'll talk about in a bit. So when we talk about health financing, we talk about taxes, because money has to come from somewhere. And there's this concept of a progressive versus a flat or regressive tax. And that so a progressive tax means that people of higher income pay a higher proportion of their income. So an income tax is an example of a progressive tax. Flat tax means everyone pays the same proportion. A regressive tax means that people of lower income pay a higher proportion of their income. So an example of this would be a GST, for example, or government and service tax, whereas everyone pays a fixed rate of the bill, but actually depending on your income, that that rate of tax is a higher or lower proportion of your income. And if you're lower income, for that same amount that you pay, this is a higher proportion of your income. So that's a regressive tax. So when we talk about models of health financing, there's a concept of adverse selection, which is a process where individuals with different expected losses are charged the same premium, and thereby you have the unfortunate outcome of those with lower expected losses dropping out of the insurance pool, leaving only individuals with high expected losses in the pool. So it means that in the private insurance market, this is disastrous. It's difficult to sustain it in the voluntary insurance market system, because the healthy people will just drop out thinking that they don't need anything, and then you leave the higher risk people in the pool and they will utilize a lot of healthcare and require a lot of payment. Cream skimming is a bit of an opposite of that. So the insurer tries to select individuals with lower expected losses in order to increase profits. So they purposely exclude people with pre-existing illness or people who might have a risk of pregnant individuals and maybe the elderly from the private insurance market, so that they are very sure that they don't have to pay a lot of money. Then there's this concept of payment, and we see these terms mentioned a lot. So deductible refers to the charges for covered services paid for out of pocket until the total cost reaches the deductible amount, and then beyond which the insurance would kick in and someone else pays for the fee. A co-insurance refers to the share of costs for covered services that the consumer is required to pay out of pocket, and this typically ranges from 10 to 20% and may or may not be subject to a limit. And the co-payment, which includes user fees and out-of-pocket payment, is the fee paid for each healthcare service with no additional administrative requirements for the insurer. So this is frequently what we pay up front when we see a doctor. Then this is also this concept of the intention of the healthcare scheme. Is it meant to provide financial protection, or is it meant to prevent moral hazard? And frequently it's a mixture of both. And in terms of achieving equity, some mechanisms that systems normally have would be means testing, which everyone I think in Singapore is familiar with, so I won't elaborate. Then waiver, which is the fee, the elimination of a fee or a reduction of a fee for a person who cannot afford to pay a user fee for a service. Exemption means that a free service is automatically provided based on medical condition, age, or other evidence, and no means testing is required. And then there's this unfortunate thing or undesired outcome of leakage, which is the problem when non-poor receive benefits, such as a reduced fee or no fee that were intended for the poor, meaning that you're charging people less than they can afford to pay. So when we talk about public health financing systems, we will talk about some stereotypical systems that we have in the world globally today, and a little bit about the historical context of it. But it is important to recognize that there's no perfect system, as much as everyone wants to believe so. And each system is really suited to the country's values and situation, including the demographics, the percentage of workers in the formal sector, taxes they can collect, cultural norms, and the ideas of solidarity. So in actual fact, the reality is that the political economy plays a bigger part than ideals of health development, because health systems evolved in the past century as governments and political parties responded to the demands of managing the country's productivity, labor needs, and the democratic voices. And in discussing it further, we will talk about the Bismarck model, the Beveridge model, the National Health Insurance model, and private health insurance scheme to a lesser extent later on. So these are the four sort of stereotypical kinds of health financing models that we have in the world today. So we'll start off with the Bismarck model, and Germany is the example for this, and he was known as the Iron Chancellor. Other countries that have a similar model will include Belgium, Japan, Switzerland, the Netherlands, and France. So you would see this is quite an European kind of, it's quite European in origin. So in this model, there's statutory health insurance for everyone, and it is administered by competing non-for-profit, non-governmental insurers. It is paid for by the employer-employee payroll tax and the general tax. In terms of the role of private insurance, about 11% of the population buys substitutive coverage or complementary or supplementary coverage. There are caps on cost sharing. So we talked about what cost sharing means earlier on, which is the extent to which a person pays for a fee, pays for a fee. So it is capped at 2% of the household income or 1% for the chronically ill. So that means if you're ill, you don't pay for, if you utilize health services, you don't pay for more than 1% of your household income, no matter what. The exemptions for children and adolescents less than 18 years of age. And so this is the German system in a nutshell. So when we talk about the beverage model, or in other words, the model that the NHS uses, there is government-run health insurance for everyone. It is paid for by general taxes and income-related contributions. There is private insurance in the sense that 11% by supplementary coverage, and there are caps on cost sharing, meaning that there are out-of-pocket caps for prescription drugs and devices. This makes £104 per year for those who need a lot. So there are exemptions in terms of drug cost sharing for those who are of the lower income group, the elderly, the children, pregnant women, new mothers, and the chronically ill. So other countries that are known to have similar systems include the UK, this is the UK, Spain, New Zealand, Hong Kong, and Cuba. So with the exception of maybe Spain and Cuba, it seems like it's in a way some Commonwealth-centric kind of system. In addition to this, we can also now discuss the National Health Insurance Scheme, and Canada is a nice example for this. Aside from Canada, other countries that also have a similar health financing scheme would include Taiwan and Korea. So in Canada, there's a regionally administered private health insurance for everyone. It is paid for by provincial and federal tax, 11% by supplementary coverage. There are no caps on cost sharing, and there are exemptions. So in terms of exemptions, there's no cost sharing for publicly covered services, and different regions have autonomy in their own autonomy in how they protect low-income individuals from drug cost. So before I move on, maybe I would also just like to clarify what the difference is between complementary and supplementary coverage, because this is frequently the reason why people buy private insurance. So complementary means that you are buying coverage for services that are not already covered for by your existing schemes, and most frequently these include eye coverage for treatment of eye and mental conditions, because most countries in the world don't cover that. So in addition to that, it's also dental conditions. So eye and dental conditions, these are the main ones that people sometimes buy complementary insurance coverage for. And in terms of supplementary coverage, it actually refers to coverage for above and beyond what you already enjoy for conditions that are already covered by your existing schemes. So that's a little technical point there. So what are some of the challenges for high-income countries? So definitely globally there's slow economic growth, and this is more relevant than ever in this COVID pandemic era. And I would just like to introduce everyone to Gapminder. It's a very fun website, free website you can go to explore a lot of data and statistics for global instance of healthcare and development as well. And if you see this graph here shows that you notice this, so shows that there's a trend that the higher income countries are, the more they tend to spend on healthcare. And if you click play when you actually go to the website, there's a time dimension to it. And don't be surprised if you see that with time, this effect is seen to a greater extent. So a problem that a lot of high income countries face is that as countries develop in terms of the GDP, healthcare services, cost of healthcare manpower, and therefore the cost of healthcare and total healthcare expenditure really has been increasing. So if we're talking about UHC, then a very important challenge really is to limit the healthcare expenditure. The other problems in healthcare UHC for high-income countries is the increasing costs, as I said, and particularly so because we would have an aging population, and then there's, as a result, a higher burden of disease from chronic care. There always is the question of whether there's overutilization and overcharging. And then there's the question of equity. So yes, we have high-income countries, but what about the poor in each of these high-income countries? So despite UHC, there's always this problem of low income or race or ethnic group being a determinant of healthcare access and health status in countries. So what are some of the mechanisms that we have to help it? Price negotiation, but the country or the largest purchases in the healthcare the healthcare kind of structure in the country is an important tool. And that's where we have this increasing importance of comparative effectiveness and cost effectiveness studies. It is important to control supply, and as much as doctors or healthcare professionals don't like to hear this from the economics perspective, this is why people talk about controlling the number of beds or specialists. Then there's also this concern of controlling demand. So again, as advocates of patient care, we may not like to hear this, but from the economics perspective, then this is where people would want to say you have to control demand by controlling the price that the person pays or the consumer pays, and therefore controlling cost sharing. And of course, with respect to the problem of equity, then a lot of it depends on advocacy or the democratic process in really pushing for maybe policy change to address some of the unseen or unheard people groups. How about low and middle income countries? So this again is a very big topic, but I will attempt to just give it some credit with this slide. Of course, there's this problem of limited resource, but in saying that, I must also say that it is a myth that low and middle income countries cannot achieve UHC. So that is a myth that people frequently think about, but we have seen with evidence that developing economies have managed to achieve UHC to a very successful outcome, and we'll discuss that later on. But certainly limited resources is a problem, and in terms of why, specifically because with less payroll tax or individual contribution to, individual contribution to the government's coffers, because in these countries there's a large proportion of people who are in the informal workforce, then you really don't have a large pool of finances to provide healthcare for, to cover healthcare for. And then as a result, there's this reliance of out-of-pocket payment, which again is a bit of a vicious cycle for the poor. So, and on top of it, there is the other issue of official and unofficial out-of-pocket payments, because in less developed countries, there is always this problem of user charges for publicly provided services that's also under table, meaning that people ask for extra money from the patients because it's just something that's part of the practice there and is not regulated. The other problem is that there's this inefficient and inequitable use of resources. So in Latin America, the Middle East and Eastern Europe, there are many organizations pooling resources and allocating healthcare spending. And these include social health insurance organizations, central and local governments, health authorities, the military and security agencies, and commercial insurers. So, for example, there are 29 public agencies in Egypt managing health financing and service provisions linked to specific schemes. So it actually makes the whole process very inefficient, administratively at least. And then, of course, there's this problem of the demographic transition, meaning that for a lot of the lower middle income countries, as they kind of progress in their economic development, they have the double burden of disease, of both infectious diseases and chronic diseases. And as the healthcare infrastructure adapts to it, it actually places an extra burden in terms of the level of service they can provide and how it can be financed. So we also have to talk about some of the current global health financing challenges today. And because this is a talk for people who are interested in the region as well, so we would just like to say that an important point is that for the past 3 decades, Southeast Asia has already become one of the world's most dynamic regions in terms of the huge volume of migrant workers moving both within the region and between ASEAN and the rest of the world. So migrant workers are extremely dependent on employers for registration with the authorities, for the insurance schemes, and without proper monitoring and enforcement, this is actually a real problem that we cannot protect migrants from being underinsured. And we can talk more about this later. In addition to that, we have the more recent problem of refugees, and then there's this other issue of undocumented refugees and migrant workers. So this is a problem because human and labor trafficking is a real issue in this region. The photo you see here in the center is taken from a photo essay by George Nichols for The Guardian. And this is actually a person called Yam, who was 29 when he was sold from Cambodia to Thailand, to a Thai fishing boat in Thailand. So he was quoted as saying this: "One of my friends said he and a few others were leaving to find work. The next day, we got a taxi and headed for Thailand. A man offered us £150 to work on a construction site, but drove us to a busy seaport instead. We sailed for days before they told us we'd been sold to the Thais to work as fishermen. And after 9 months at sea, I knew I had to escape. Now I have a newborn baby, a wife, and no prospects of work. Maybe I'll try to find work again in another country. So this is to show you that that these stories are real and that there's a big proportion that is unseen out there, and their healthcare also is a pressing need. So again, in a tight nutshell, some solutions include this discussion of what we call the health development nexus in the global health financing kind of circle. So it is this concept of including refugees in the workforce and therefore the health financing system at the host countries. So the concept is that if you welcome them realistically knowing that they might be in the country for years or decades, then allowing them to work allows them to contribute to the economy, earn money, and also gives them the power or ability to purchase health financing schemes that you can make available in your country as well. So this in a way might be a more sustainable solution to the refugee crisis. Another way is to just allow migrants to directly enter some of the schemes that you have existing in your country. And of course, the other part is advocacy and law enforcement with respect to preventing the issue of human trafficking. So again, shifting gears, if there are no questions, we'll move on to maybe some case studies in Singapore and Thailand. Okay, so it seems like there are no pressing questions, and I think it is just important to point out that, well, I'm bringing up these two case studies because these are the two countries that I'm most familiar with at this point in time. In a lot of ways, they are very different. We're very different countries, and it is not meant to be a direct comparison between the two, but it's just an avenue for us to discuss some of the concepts that we talked about earlier. So when we talk about Singapore's healthcare financing system, as always, we have to talk about the context. So again, I think this story is not stranger to anyone, but we were initially a very lifeless island in the middle of an archipelago, and then when Sir Stamford Raffles came to our shores, we developed from a third world to a first world country. Later on, after first Raffles coming in to establish Singapore as a seaport, and then post-independence in 1965, with all the progress that we had as we positioned ourselves as a more modern seaport in the current era. So because of that, Singapore has a lot to be proud for, but just so that we are reminded of what happened, I think at that point in time, the odds were against us, and globally, a lot of people thought that Singapore wouldn't make it. So in terms of how our financing values were kind of shaped in the beginning, you can kind of rationalize it to saying that in the beginning, self-sufficiency was very important. And we had to prove that whatever system we had or adopted, it was something that could be sustained. Economic security is very important. And of course, we have a very secular environment. In a way, it's an autocratic system because we have a main party that is able to pass constitution and make decisions very efficiently. And there's also this very real fear of moral hazard in the way we have structured our healthcare financing system. So what model do we have? Well, we have the 3 M's and +1. So basically MediShield, MediFund, MediSave, and then there's Medication Assistance Fund. In a nutshell, if we were to look at indices that people frequently talk about, public healthcare expenditure is 2.1% of the GDP in 2015, and in 2014 it was 41% of total healthcare expenditure. And in a way, this is something to be proud of, because if you recall from the gapminder slide I showed you earlier, among the countries of higher GDP to the right of the axis, Singapore is doing quite well in terms of how our total healthcare expenditure is kind of lower on the y-axis. Out-of-pocket expenditure is 94% of private health care expenditure. We have the MediSave, which is the compulsory savings scheme, MediShield Life, which came on more recently, and then MediFund. And of course, there's the 4th M, which I think is increasingly important in healthcare today. And as practitioners, I think most of us would recognize it because we know that it's for low-income individuals and for people who need financial assistance for some of the costly drugs that are not on the standardized drug list. and it is important. And it is used for, and I think it's increasingly used because we have a lot of developments in terms of the therapies that are available for chronic conditions today. And in this aspect, a lot of our patients benefit from this. So in a nutshell, we can say that in Singapore, there are government subsidies for healthcare at all public institutions, and there's an endowment fund for low-income individuals. We do have a national catastrophic health insurance with premiums paid for from compulsory medical savings schemes. We have subsidies which are paid for by general taxes. There is a private insurance, and this is heavily regulated by the government, and they provide approved supplementary and complementary plans. There is no cap on cost sharing, and there are exemptions based on means testing and specifically for the low-income population. So now we talk about Thailand's health financing system. And this is actually a very interesting story. So first, I must point out that Thailand has the rare distinction of being the only state in Southeast Asia to not be colonized. But it was among the first to adopt a UHC system with a value system that is very reminiscent of the European health financing values. And to kind of understand that, we must appreciate the history in Thailand. So in the middle 19th century, during the reign of King Chulalongkorn, the fifth king of the Chakri dynasty, kings and other leaders of Thailand began to travel abroad, and they brought back innovations from Western countries, and we're very happy to go overseas to learn from them. So many years later, compelled by the poor state of patients that he saw in the hospital, Prince Mahidol, the father of the future King Bhumibol or Rama IX, decided to study public health and medicine in Harvard. And upon his return, he overcame odds to work as a doctor while instructing students, and he set up a scholarship for many to study overseas. So in the same spirit, by 1975, in more modern era, a lot of health services were already made available to the poor free of charge. And to kind of put more focus in the rural health, in 1982, there was a freeze on capital investments in urban hospitals. And then despite the Asian financial crisis in 1997, when in 2001, it was reported that 18 million people were uninsured, after the successful election result of the Thai party, it became a catalyst that brought about the fruition of reformist works of several health policy experts from many years before, and therefore the UHC came about. In 2001, the UHC was introduced into Thailand, and it is famously referred to as the 30 baht or batong kind of scheme. And this means, well, at that time, it meant that if you were to visit the outpatient clinic or be admitted for whatever condition, all you have to do is pay 30 baht or 130 Sing dollars approximately, and that is all you would need to pay for everything. It is not, so I think in 2006, they realized that the administrative fees of collecting this actually was more expensive than the amount of money they actually collected. So they stripped off the 30 baht aspect, and actually now there's no 30 baht at all, but we still call it 30 baht, I suppose, out of sentimental reasons. So knowing this, what are some of the values that we can say that the system has? There's a strong element of solidarity, inclusion, and evidence-based, because for a country to embark on UHC, and especially when it's still in its developing stages, then a lot of the decisions as to what you include and what you want to pay for has to be strongly dependent on health technology assessment studies. So in Thailand, there's actually a pluralistic health financing system, meaning there are three main models. It retains the compulsory social security scheme for employers in the formal private sector and the civil servant medical benefit scheme for government employees. And because these had been in place long before the introduction of the 30 baht scheme. And understandably, because merging all these schemes overnight for such a large country would not be feasible or immediately well received by the various ministries operating the existing schemes, or the civil servants or the trade unionists who have been benefiting from these employment-based schemes for a long time. So when the 30 baht scheme was introduced, it was put into effect by pooling the Ministry of Public Health's budgets for public hospitals, other health facilities, and the previous low-income and voluntary health card schemes with a little bit of additional money. So as a result, you see from this schematic here that 97% or almost 98% of the country has health coverage. And how do they control the price? So they do so via the use and production of generics, but of course not all countries can do this. And this is something that's another topic for another day, but it has an interplay with the World Trade Organization and other pharmaceutical companies and regulations and patents as well. But definitely there's a strong focus on using generics. There is such a thing as the National List of Essential Medicine and Pricing. So medicines are included into the national list according to the generic rather than brand name. And if more than one product is clinically equivalent in a therapeutic group, then only one product will be listed. Then beyond that, low-cost medicines in the list are procured locally, and if they are high-cost medicines for all public health providers, then they would be procured centrally in order to increase the government's negotiating power through bulk purchase. So this element of negotiating power is an important concept that we can talk about later as well. And of course, there's also this importance of limiting or establishing a ceiling in drug prices. And then the last component is HITEP, or this is essentially Thailand's Health Technology Assessment Agency, or the equivalent of ACE in Singapore, which is an agency that rigorously uses evidence to control the content of the insured bundle and the price negotiations for the suppliers of pharmaceuticals and other medical supplies. So basically, it's very strong science in cost effectiveness analysis, so that you have the confidence to say, okay, this is sure to benefit the population and it is worth the country's money, or maybe this is beneficial, but it is a bit expensive, and then I'm going to use this data to maybe negotiate with the drug company. Can you bring it down? If not, I won't buy it all for the whole country. So then in terms of Thailand's healthcare financing system, there is a special element that I think is important to highlight, which is the extra provision it provides, the extra provision for migrant workers. So there's such a thing as the compulsory migrant health insurance scheme, because as we alluded to earlier, there's a lot of migrant movement for work in this region. And in fact, in Thailand, migrant workers constitute 5% of the workforce and 6.2% of the GDP. But the problem with this is that only 1/3 of these migrant workers are legally registered. So if they are not legally registered, then in a way it's actually not possible for them to benefit from this government administered compulsory migrant health insurance scheme. So this is where the NGO work kind of comes in. So when I was in Thailand, I was involved with this NGO called Dream Movement that launched M-Fund, which is essentially a community-based health insurance scheme. And what it does is that it's the gap for undocumented migrants and workers who could not otherwise access healthcare financing tools, and many of whom are staying in border areas where they are already actually benefiting from the healthcare services of many NGOs and state healthcare providers. And the problem in these areas was that a lot of these fees were being overwritten because they just don't have money to pay. So it was first launched in the Tak province along the Thai-Burma border in September 2017 to provide health coverage for undocumented migrants and to mobilize resources for both NGO and government providers caring for them. So it does so by recruiting community health workers to give information to migrants, and they operate using iPads to link member data to a remote database. The members are given a card with a QR code, and then when they utilize healthcare, the hospital identifies the member via the card. They scan the QR code, and then the hospital is later reimbursed by M-Fund. So in a nutshell, what can we kind of glean from Thailand's healthcare financing system? We know that it debunks myths. You don't have to be a very rich country to be able to achieve a UHC. And we also know that even though it may appear difficult, it is possible to produce good outcomes and to show for it. So there's evidence that infant mortality was decreased after the implementation of the UHC. There was also increased productivity in the sense that employees were less likely to report that illnesses had prevented them from going to work. The effect was larger for workers above the age of 65, and significantly fewer people reported that they were too sick to go to work. So here we come on to the last part. I'm not sure how I'm doing for time, but I presume I have to kind of wrap things up.
Yes, I think it would be good. So we have some question and answer time.
Okay. So maybe I'll just quickly go through some of the points. There's some parameters that we frequently talk about in terms of how premiums are collected, how progressive or regressive this is, what services are covered, and what's the order of coverage. I think an important ethical question here also is who decides and who should decide, because sometimes depending on the system is the payer, provider, or consumer, and there can be some problems if it is actually the provider, the payer who decides, but the payer is neither a healthcare provider nor a consumer. And I think the US insurance market is a good example for this. How is reimbursement done? And I kind of alluded or mentioned it earlier when we talked about how it could be by global fees, capitation payment, fee for service, or case or diagnosis based payment. And each of these various payment reimbursement types have their own pros and cons. And frequently you find in countries we use a mix of them to maximize efficiency, quality, and satisfaction. In terms of evaluation, we have to think about whether healthcare resources are allocated and spent efficiently, whether the population is protected financially, whether everyone is protected, whether there's access to proven treatment and prevention measures, and whether we think the quality is sufficient. So I think sorry, I do have a few more slides, so I'll quickly try and run through this. If for those of you who are kind of more visually inclined, I think this framework helps. I came up with it when I was doing an evaluation during my MPH, and basically I would just like to bring attention to the column of impact, which is that it's important in terms of talking about health financing for the global health context, that whatever schemes we're talking about will ultimately kind of mobilize resources for the healthcare providers or the hospitals in the region, whether they actually protect the vulnerable, whether they truly objectively improve health, and whether there's a true social inclusion, meaning that the poorest of the poor are included as much as possible. And we want to see that there's a flow of good measurable outcomes in terms of the various stages of this impact model, meaning that you want to show that your impact is attributable to the scheme itself. Okay, this is more about the NICE data from Thailand. It summarizes the kinds of payment methods for the various schemes. And maybe I'll just show you I just ask that you pay attention to the third figure, which is a very nice figure again. It shows that for the Universal Health Coverage Scheme, the 30 baht scheme, it's very notable for having included many more who are of the lowest income quintile in the country. And if you look at the other schemes, you would know that they would otherwise not have been included without the 30 baht scheme. So this is a nice kind of measure or a way of evaluation to show that there's social inclusion. Okay, so this is talking about the evaluation of the migrant health scheme in Thailand that I was involved in. Essentially, it talks about how in some ways you have data limitation for for newer schemes or places where your data collection or management process is in its nascent stages, but there's still ways to evaluate the receptibility of these schemes. And an important point in this process of including health coverage also is that is important to increase the knowledge and awareness of health and the importance of it among the beneficiaries, and in this context that was achieved. So I think I'm just gonna close off by saying that while after all that, so my current interest is to work on migrant healthcare access for those in Singapore, but it's just beyond the kind of scope we have here. But if any one of you is interested in this topic, please feel free to contact me after this, and we can discuss this online. And I would just like to conclude by saying that at the very least, I hope that at the end of the talk, you are convinced that UHC is something that all healthcare professionals should understand and can advocate for. The path to UHC may be varied in different countries, and it's actually influenced heavily by the local and historical context. So it is important to have the awareness of the complexities of challenges to health financing for the world today. And finally, there's just always an evolving, there's a need for an evolving health financing systems to maximize the effectiveness, efficiency, and equity. And there's also a need for continued monitoring and evaluation and appropriate change to some of these systems. Okay, with that, I thank you for your attention. I thank the organizers of this talk for inviting me to speak. If you would like to stay in touch, please feel free to email me because at this address here, as I apologize in advance, my HMail account has space limitations. So now we shall open the floor to questions.
Yeah. So thank you, Orlanda, for a great talk. That was really a wealth of information. So I'm not surprised it took you the time it did to go through it. So we are left with a little bit of time for questions. And someone has asked, can you please reiterate the significance of quality within universal health coverage? So maybe like a little bit more focus on what that means.
Okay, so like I said, we talked about the three core principles: finances, the population, and quality. And I think quality can't be forgotten because, like I said, it's something that sounds like a very soft topic to many people, but there is literature out there and a consensus that it can be defined by what the IHI says is the six core tenets of quality, and it means that we're giving patients care that's safe, that is proven to be effective. So how this is relevant is because, like I said earlier, it's not enough to just show that you're paying for people's healthcare, but you want to show that you're paying for healthcare that works. So it's not just about people having zero or minimal out-of-pocket payments and the government paying a lot, but you want to make sure that your healthcare works. So that's why when we talk about quality, it's important to know what some objective quantitative indicators are. For example, percentage maternal mortality, percentage infant mortality, percentage of people who have good control for diabetes, and percentage of those who have diabetes who end up having end-stage renal failure. So these are important kind of quantitative measures that you can use to track so that you know that you are actually providing effective UHC. But also because I think there's always the fear of moral hazard and the risk of overutilization, which we cannot ignore as much as we want to. So in a way, if we see indicators of high utilization, but we don't see the indices of quality to follow that, then it makes us question our system and how we are structuring or incentivizing provider behavior.
Yeah. So before we go on to the next question by the audience, I'll actually add a question of my own, which looks at the other aspect of it. So there's a, assurance of quality, but it's also universal health coverage. The word is universal, but there have been a lot of discussions about who actually gets covered and what are really some of the issues of access to care. Who are the populations and what is the difficulty in accessing this, both tangible and sometimes intangible. Could you comment on that a little bit?
Yeah, so that's a great question. So I think the other problem with UHC, of course, is that we have to know that it's not just about the policy and the health finances and what the technocrats do, but in reality, the health service provision and the infrastructure is very important. And I think maybe we are not as able to appreciate it in Singapore, where we're very, very small. But I think in very large countries where there has been a lot of effort to kind of bring up UHC, as they are in development. The key problem also is the quality, the aspect of geographical access in terms of the rural areas and what facilities we have there, and as well as the problem of getting adequate manpower there. So you may be able to start training doctors and nurses slowly, but then after you train them, how do you also incentivize them to go all out to the far-flung areas that maybe they are trying to escape to kind of break out of the poverty cycle? So there's a problem, and I think it's a very current topic because I must mention that Iran has been widely touted for including a lot of Afghan refugees into their healthcare. So there's like this inclusion of them into the UHC to some extent because they allow them to purchase health insurance. But then there's also this component of access to care that's not discriminatory. So if the refugees tend to be in more rural areas to begin with, they can't even access care physically, or then if they are there but they can't access care that is free of discrimination, that may be unintentional just because they don't have people that speak their language. So access is a key part of it. Yeah. Thanks for bringing it up.
Okay, now to change tacks a little bit, you have a question about someone's asked you that you shared about possible solutions to reduce health disparities of migrant workers in Singapore. Could you comment on that? And also, they asked the question, what would that impact on national healthcare expenditures? So now taking the conversation to our own backyard.
Okay. I thank you for that question. I don't know who you are, what your background is, so it'd be nice to hear a personal perspective on this. But I think in terms of the healthcare disparity for migrants here, then we got to talk about really drilling down to the specifics of it. So like Amina, we talked about it before, and we were working on it together. But some things that can be worked on definitely is the ceiling of care for inpatient care if they are admitted for catastrophic events. Or maybe a topic close to heart would be the ambulatory care that can benefit from in terms of the screening and prevention or treatment of long-term chronic diseases, because we do know that there's a large population and a lot of them may actually be reaching the middle age group, and there is the real concern of NCDs being a problem for this population. So these are gaps in terms of healthcare services that we want to try to help. And in terms of what we can do, so access, number one, in terms of healthcare providers that have the bandwidth to meet these aims. And realistically, we know that as much as we want to, the public primary healthcare system or the specialist outpatient care system is actually very heavily burdened right now. So then we got to think out of the box to think about how can the 80% of private care providers out there for primary care kind of be part of this solution if they're so inclined. And then in terms of the financing, so this is a topic that I've been trying to work on as well, then how can we mobilize resources for them? And as I said earlier, every country has a very specific kind of context, so we can't take solutions wholesale. But what I'm working on now is to see how elements of a CBHI or like a voluntary supplementary health insurance scheme for migrants may help in this, but of course it would need the support technically, legally as well, and in terms of money from some of the private insurance out there and from the government and some private actors as well. But we really have to engage them more to find out about their healthcare perspectives in terms of migrants, their healthcare perspectives, how much they're actually willing to pay and how much they know about these healthcare risks that they're exposed to. And I think that's one of the first steps in it. And I think we can take this offline. You can email me and can talk more about that after this.
So we are right out of time, so I won't kind of follow the other questions, but Orlanda has very nicely given you her email, so I think feel free to email her, and I'm really happy to keep this kind of conversation and dialogue going in other forums also. So we will look for opportunities to do that. So with that, I'll just say thank you again. That was really, like I said, given a lot of food for thought for people, and these are important issues that are, debated all across the world all the time. So it's nice to be kind of part of that conversation and certainly see how we can apply it in Singapore also. So with that, thank you, Orlanda. Thank you to the audience. It was great to have all of you with us, and hope to see you next month at our next Global Health Seminar Series. Bye-bye.
Thank you.